If you're over 70 and your doctor recently congratulated you on getting your blood pressure down to a perfect 120/80, I need you to stop what you're doing and listen carefully. Because a major study published in the Journal of the American Medical Association tracked more than 15,000 older adults for 5 full years, and what the researchers discovered directly contradicts nearly everything we've been told about blood pressure targets for seniors. The participants with that so-called perfect blood pressure had a 28% higher risk of serious falls, and here's the part that stunned even the researchers. Their mortality rates were actually worse than the seniors, who walked around with moderately higher numbers. In the next 15 minutes, I'm going to show you the exact blood pressure range associated with the longest survival in older adults, why the standard target that works beautifully for a 50-year-old might be genuinely dangerous after age 75, and one simple 3-minute test you can perform at home tonight that could prevent a devastating life-altering fall. I'm Dr. William Lee, and this information could genuinely protect your life or the life of someone you love deeply. Before we go any further, I want you to do something for me. Drop a comment right now with just your age. Nothing else, just your age. I genuinely want to see who is watching this, because the information I'm about to share applies very differently depending on whether you're 65, 75, or 85. And if you have ever felt dizzy or lightheaded when standing up from a chair, from the dinner table, or from getting out of bed at night, I want you to add the single word dizzy to that comment. This is critical information that I personally need to see, and you will understand exactly why in about 3 minutes when we get to the part that most doctors are completely overlooking. Let me paint you a picture of what's happening in doctors' offices all across this country at this very moment. A 78-year-old walks in for a routine checkup. Their blood pressure reads 145/86. The doctor glances at the computer screen, pulls up the standard guidelines, sees that recommended target of less than 130 systolic, and almost reflexively reaches for the prescription pad. One medication gets added. Then a few months later, a second one. And sure enough, over the next 6 months, that blood pressure comes down beautifully to a textbook 124/78. The doctor is pleased. The patient practically gets a gold star on their chart. Everyone in that room believes this is a success story, a job well done. But here is what the guidelines simply do not account for. That same 78-year-old now gets up in the middle of the night to use the bathroom, and their blood pressure plummets from 124/78 down to 88/56 within a matter of seconds. Their brain suddenly isn't receiving enough blood flow. The room begins to spin. They reach out for the wall to steady themselves, but they miss. And in that single instant, we are no longer talking about numbers on a chart. We're talking about a fractured hip, emergency surgery, 3 weeks in a rehabilitation facility, and a cascade of complications that far too often ends in the permanent loss of independence or something even worse. This is not a rare event. This scenario unfolds thousands upon thousands of times every single day, and the tragedy is that so much of it is entirely preventable. The research I mentioned, published just months ago in JAMA Internal Medicine, should have been front-page news everywhere. It should have been discussed on every morning program and in every medical office. But the uncomfortable reality is that most doctors still haven't read it, and most patients have never even heard it exists. That enormous gap between what the science actually shows and what's being practiced in everyday medicine is quietly costing lives. Now here comes the part that's going to sound completely counterintuitive, and I need you to stay right here with me, because this is where your entire understanding is going to shift. For decades, the mantra in medicine has been beautifully simple: lower blood pressure equals better health. And for middle-aged adults, people in their 40s and 50s, that statement is largely true. Getting blood pressure under control in midlife genuinely does prevent heart attacks, strokes, and kidney disease years down the road. The evidence supporting that is absolutely rock solid, and I would never tell a younger person to ignore it. But something fundamental changes in the human body after the age of 75. This research showed clearly that seniors with a systolic blood pressure sitting between 130 and 145 actually lived longer than those with pressure pushed below 120. They experienced fewer falls, fewer fractures, fewer hospitalizations, and notably better cognitive function over time. Meanwhile, the group that achieved that textbook, picture-perfect 120/80, suffered higher rates of dizziness, higher rates of syncope, which is simply the medical term for fainting, more acute kidney injury, and yes, higher mortality overall. The perfect number, it turns out, was quietly hurting the very people it was supposed to protect. If you're the kind of person who wants to understand the why behind the numbers rather than just being told what to do and sent on your way, then what I'm about to explain will hand you an entirely new framework for thinking about blood pressure as you age. Here's the core truth. Your cardiovascular system at 75 is not simply an older version of your cardiovascular system at 45. It is fundamentally, structurally different in ways that completely change what your blood pressure numbers actually mean for your health and survival. Let me walk you through the 3 critical changes that happen with aging and explain precisely why they demand different targets. First, arterial stiffness. As you age, your arteries gradually lose their elasticity. Picture a brand new garden hose compared to one that's been baking out in the sun for 20 years. The old one is stiff, brittle, and far less flexible. Your arteries go through a remarkably similar process called arteriosclerosis. When your heart pumps blood into these stiffened arteries, they can no longer expand and gently absorb the pressure wave the way young, supple arteries once did. This means your body genuinely needs a slightly higher baseline pressure just to ensure enough blood reaches your brain and your kidneys, especially when you're standing upright and that blood has to fight its way up against gravity. Second, your baroreceptor function declines. Baroreceptors are tiny pressure sensors nestled in your blood vessels that detect changes and instantly signal your brain to make adjustments. When a young person stands up, their baroreceptors catch the drop within milliseconds and immediately fire off compensatory responses. The heart rate climbs, blood vessels tighten, and pressure stabilizes before the person even notices. But with age, these baroreceptors become dull and sluggish. They respond far more slowly. So if your baseline pressure has already been medicated down to a low number and your baroreceptors are lagging behind, you experience that dangerous plunge in pressure the moment you stand. That condition has a name, orthostatic hypotension, and it is a leading cause of falls in seniors. Third, your medication metabolism changes dramatically. Your kidneys and your liver simply do not clear medications as efficiently at 75 as they did at 45. A dose of blood pressure medication that is perfectly reasonable and safe for a middle-aged adult can be genuinely excessive for an older one. The drug lingers longer in your system, exerts a stronger effect than intended, and can push your pressure far lower than anyone planned. 3 separate medications at the same dose can behave like 5 in an aging body. Now let me tell you exactly what this landmark research uncovered, because the specific details truly matter here. The study followed 15,342 adults over the age of 75 for an average of 5 years. These were not carefully hand-picked, unusually healthy seniors living in perfect conditions. These were real-world older adults, people living with diabetes, people who had suffered prior strokes, people with heart disease, and varying degrees of frailty. The researchers tracked their average blood pressure and then watched carefully to see what happened to each of them over those 5 years. They sorted the participants into distinct groups based on their systolic pressure. One group stayed below 120, another sat between 120 and 130, another between 130 and 140, another between 140 and 150, and a final group remained above 150. And here is what they found. The lowest mortality rate of all belonged to the group with systolic pressure between 130 and 140, not below 120, not the textbook perfect number that gets celebrated, the moderate range. Those with pressure pushed below 120 carried a 28% increased risk of serious falls requiring hospitalization, higher rates of acute kidney injury because their kidneys couldn't function properly at such low pressure, and an overall mortality rate that was 14% higher than the 130 to 140 group. Now, to be fair and balanced, the group above 150 also faced real problems, exactly as you'd expect: higher stroke rates and more cardiovascular events. Very high pressure remains a genuine danger. But the great surprise of this study, the finding nobody anticipated, was that very low pressure was just as dangerous as very high pressure for these older adults. The sweet spot, the range tied to the longest survival and the best quality of life, sat higher than our conventional guidelines have been recommending for years. Let me make this real for you. Imagine you're 76 years old, walking into your doctor's office for a routine visit. Your pressure reads 142/84. Your doctor looks concerned, checks the guidelines, and says, "We really need to get this down to at least 130, ideally closer to 120. You start a medication. 2 months later, you're at 128/78. Your doctor is pleased, but suggests a second medication to nudge it just a bit lower. 2 more months pass, and now you're at a flawless 122/76. Your doctor smiles. Everything looks perfect on paper. But then you start noticing things. When you rise from your chair to answer the phone, you feel a wave of lightheadedness. When you stand from the dinner table, for a split second the room seems to tilt sideways. You mention this to your doctor, who reassures you it's probably just age, your vessels adjusting slowly, and advises you to simply stand up more gradually. But what's genuinely happening is far more serious. Your pressure looks beautiful while you sit still in that office, but it's collapsing when you stand, dropping from 122/76 down to perhaps 95/60. Your brain is enduring repeated episodes of inadequate blood flow, and you are at high risk for a catastrophic fall, yet nobody is checking for it because your sitting number looks so perfect. And here's what genuinely troubles me. There is a simple test, one that takes about 3 minutes, that can identify whether your medications are quietly setting you up for a fall. It's called orthostatic vital sign measurement, and most doctors are not performing it routinely during visits. So let me teach it to you right now, so you can do it at home tonight, because this knowledge is potentially life-saving. You'll need a home blood pressure monitor, available at any pharmacy for about $30. Here's the exact protocol. Lie down flat on your bed or couch and simply rest for 5 full minutes. After those 5 minutes, check your pressure while still lying down, and write down both numbers, the top and the bottom. Now stand up and immediately check your pressure again while standing. Do not wait around. Check it right away, and write those numbers down too. Now compare them carefully. If you're systolic, the top number dropped by more than 20 points, or you're diastolic, the bottom number dropped by more than 10 points, you have orthostatic hypotension. That is a genuine red flag. It means your medications may be too strong, or your target pressure may simply be too low for your physiology. Let me give you a concrete example. Say your lying pressure is 125/78. That looks wonderful on paper. But when you stand, it drops to 98/64. That's a 27-point systolic drop, and that is dangerous. Your brain is running on insufficient blood flow whenever you're upright, which is most of your waking day. You might feel completely fine lying down, but the moment you're vertical, you're operating on empty. This is the test your doctor should perform at every single visit if you're over 70 and taking blood pressure medication. If they're not doing it, do it yourself and bring the results to your next appointment. So what should your blood pressure actually be? Let me give you the ranges the research suggests are tied to the best outcomes, but please understand, these are guidelines, not rigid rules. Your individual target must be decided together with your doctor based on your complete medical picture. For generally healthy, active adults aged 65 to 74 with no major conditions, a systolic range of 130 to 140 appears reasonable, offering cardiovascular protection while keeping your organs well supplied. For relatively healthy adults aged 75 to 84, The evidence supports a systolic range of 135 to 145, higher than the younger group, accounting for stiffer arteries and slower baroreceptors. For adults over 85, or anyone frail regardless of age, a range of 140 to 150 may be most appropriate, because at that stage preventing falls and preserving quality of life often outweighs aggressive lowering. And what about that bottom diastolic number? For older adults, it should generally stay above 65, ideally between 70 and 85. Very low diastolic pressure reduces blood flow to your heart muscle during its relaxation phase and can cause serious problems. If yours consistently sits below 60, that's worth discussing with your doctor even if your top number looks fine. Consider a 73-year-old with type 2 diabetes and one heart attack 5 years ago, whose pressure reads 108/86. Should they aim for 120/80? Probably not. Should they settle for 150/90? Also probably not. For someone in this exact situation, research suggests a target around 130 to 135 systolic might be optimal, low enough to protect against cardiovascular events, given the diabetes and cardiac history, but not so low that it invites orthostatic drops and falls. And critically, that target should be reached gradually, with careful monitoring for side effects, with orthostatic pressure checked and symptoms assessed every time a dose is adjusted. Dizziness, fatigue, and foggy thinking can all signal that pressure has been pushed too low, even when the numbers look flawless. And here's something most people never realize. Blood pressure fluctuates throughout the entire day. A single reading of 148/86 doesn't mean it's always that high. It might be 132/78 in the morning and 145/84 in the evening. What truly matters is the average over time, which is exactly why home monitoring is so valuable. It paints a far more accurate portrait of your true pressure than a handful of occasional office readings ever could. You might be wondering why, if all this research exists, your own doctor hasn't mentioned any of it. The answer is complicated but important. Most guidelines are built on large clinical trials conducted over many years, and the landmark trials that established 120/80 as the ideal were done primarily in middle-aged adults. When those results emerged, the guidelines were applied broadly across every age group, under the assumption that what benefits a 50-year-old must also benefit an 80-year-old. Only over the past decade have researchers begun studying older populations specifically, and they're discovering that one size simply does not fit all. Unfortunately, it takes years for new research to reach the guidelines, and even longer to change everyday practice. There's also a psychological factor at play. For decades, doctors have been taught relentlessly that lowering blood pressure saves lives. That message has been drilled in deeply. Shifting to a more nuanced view, one that says moderate elevation is sometimes acceptable or even preferable, requires doctors to think critically about each individual patient rather than reaching for a universal target. And in a healthcare system where physicians often have just 15 minutes per patient, that thoughtful, individualized approach becomes genuinely difficult to deliver. Let me show you how different two people of the very same age can truly be. Both are 81. The first lives independently but manages several chronic conditions: mild heart failure, stage 3 chronic kidney disease, and osteoarthritis. Their pressure is 158/88. The second is also 81, but healthy, active, plays golf twice a week, with no significant medical problems, and their pressure is also 158/88. Same number, same age, but two entirely different risk profiles. For the first person, layering on multiple medications carries real danger. Those drugs could drop their pressure too far when standing, worsen fragile kidney function, and trigger dizziness that, combined with osteoarthritis, could prove catastrophic in a fall. A wiser path might be lifestyle changes first, then perhaps a single low-dose medication with careful monitoring, accepting a target closer to 140 to 145. For the healthy golfer, 158/88 might still warrant attention, but again, not aggressive treatment. Lifestyle changes alone might bring them to 145/84, which for an active person that age could be perfectly acceptable without any medication at all. Same numbers, different people, different approaches. This is what we mean by treating the patient, not the number. So let me give you concrete action steps you can begin tonight. First, if you're over 70 and on medication, get a home monitor and check your pressure at the same times each day for 2 weeks, morning and evening, keeping a written log. Second, perform that orthostatic test I described. 5 minutes lying down, check, then stand and check immediately. A drop over 20 systolic or 10 diastolic needs discussing with your doctor. Third, assess your symptoms honestly. Dizziness when standing, unexplained fatigue, trouble concentrating, these may all signal your pressure is too low. Fourth, schedule a visit specifically to discuss your targets. Don't simply accept a blanket demand for 120/80. Ask what's appropriate given your age, conditions, and function, and bring your logs. Fifth, if medications are causing side effects, speak up. Never suffer in silence assuming dizziness is just your lot in life. Doses can be lowered, drugs can be swapped, and targets can be adjusted to protect both your heart and your quality of life. Here's what you now understand that most people, and frankly many providers, do not fully grasp. Blood pressure targets should never be universal. A 45-year-old and an 85-year-old cannot be held to the same standard. For older adults, especially those over 75, a systolic range of 130 to 145 is tied to the longest survival and best quality of life. Below 120 raises the risk of falls, fainting, kidney injury, and possibly cognitive decline. Above 150 raises cardiovascular risk. The sweet spot lives firmly in the middle. You've learned that orthostatic hypotension is often more dangerous than moderately elevated sitting pressure, and you've learned how to test for it yourself. You now hold the language and the knowledge to have a genuinely informed conversation with your doctor. You're no longer a passive recipient of advice. You're an active, empowered participant in your own care. You are now more informed about blood pressure in older adults than probably 90% of people your age. You understand the nuance. You know that one size does not fit all. If this gave you clarity, if it answered questions you've been quietly wondering about, if it handed you the confidence to advocate for yourself, then I've done exactly what I set out to do. Drop a comment right now saying informed if you feel more equipped to talk with your doctor. Share this video with any friends or family members over 65 who could benefit, and subscribe to this channel, because my mission is bringing you research-based health information that's accessible, practical, and genuinely life-changing. In my next video, I'm going to reveal the 3 supplements that research actually shows can support healthy blood pressure naturally, and the 2 wildly popular ones that are complete wastes of your money. You will want to see that, because the supplement industry is drowning in misleading claims, and I'm going to show you precisely what the evidence says. I'll see you there. This video is for educational and informational purposes only, and is not intended as medical advice. Blood pressure management should always be individualized based on your complete medical history, your current health status, and other personal factors. Never adjust or discontinue any medication without first consulting your healthcare provider. The information presented here is based on current research, but it should never replace professional medical care. Always consult with a qualified healthcare provider before making any changes to your treatment plan or your medications. Your health is worth that conversation.